Before beginning the procedure, gather the following materials: antiseptic solution, a large bore needle, lidocaine, spinal needles and syringes, scopettes, sterile gloves, a speculum, a tenaculum, cervical dilators, and the IPAS manual aspirator and appropriate cannulae. After obtaining the patient's informed consent and assisting the patient into the lithotomy position, the clinician will insert a speculum into the vagina to allow visualization of the cervix. The speculum should be fixed in the open position to allow adequate visualization throughout the procedure. Now, the cervix can be prepped with an antiseptic solution such as betadine applied in a circular motion using scopettes. Prepare 2 10 cc syringes with 1% lidocaine. Using a 20 gauge spinal needle, inject 2 cc's of 1% lidocaine into the cervix at the 12 o'clock position. Allow 2 to 3 minutes for the anesthetic to take effect, and then grip the anesthetized area with a tenaculum. Gently adjust the tenaculum to better visualize the cervical-vaginal junction at the lower portion of the cervix. Note how the clinician holds the tenaculum to stabilize the cervix. Insert the spinal needle into the cervical-vaginal junction at the 4 o'clock position and aspirate to ensure the needle tip is not within a blood vessel. Inject the remaining 8 cc's of 1% lidocaine from the first syringe at this position. Switch syringes and insert the spinal needle into the cervicovaginal junction at the 8 o'clock position. Aspirate to ensure the needle tip is not within a blood vessel, and then inject the other 10 cc's of 1% lidocaine at this position. When injecting, it is imperative to avoid the 3 o'clock and 9 o'clock positions of the cervicovaginal junction, as this is where major blood vessels supply the cervical tissue, so risk of intravascular lidocaine injection or bleeding complication is high in these locations. Sterile technique should be used from this step forward. Be careful to hold dilators in the center to avoid contaminating the ends, which will be inserted through the cervical canal. Here, you see the clinician placing gentle traction on the tenaculum to straighten the cervical canal before inserting a rigid cervical dilator with a slight rotatory movement. This rotatory movement allows the cervical canal to guide the path of the dilator during insertion. Gentle pressure may need to be applied with initial dilation through the internal cervical os. Sizing of dilators will vary based on type of dilators used and gestational age. Be sure to familiarize yourself with the instruments available at your institution. Attach the appropriately sized cannula to the end of the aspirator, taking care to keep the cannula sterile. For the IPAS manual aspirators being used in this simulation, the cannulae have sizes that match the gestational age. For example, a size 7 cannula would be used for a 7-week gestation. Activate the aspirator by pressing the 2 buttons on the side of the device. Then, pull back on the aspirator plunger to create a vacuum within the device. Insert the cannula into the uterus with gentle, steady pressure. Once inside the uterus, gently advance toward the fundus. If the cannula touches the fundus, withdraw about 2 centimeters before activating the vacuum suction so as to avoid uterine perforation or damage. Engage the vacuum suction by pressing the 2 buttons on the sides of the aspirator. After engaging the vacuum suction, slowly withdraw the cannula while rotating in 360-degree circles. Repeat this until there are no longer products of conception being withdrawn with activation of the vacuum suction, and the cannula has a gritty texture when scraping against the interior uterine walls. Empty the aspirated contents in between each pass. On the last sweep with the aspiration cannula, make in and out movements in all 4 quadrants of the uterus before withdrawing the cannula for the final time. Lastly, remove the TENACULUM and examine the cervix for lacerations or other trauma prior to removing the speculum.